So good evening friends. Dilemma, and we are meeting on this platform for last almost more than 6 to 7 years, and mostly we are online, and we have done meetings. Good evening. Conferences, we have done physical meetings, and this is a hybrid platform. So I welcome each one of you who have joined online. You all are aware about diabetes dilemma, series of interesting discussion events which helps us in day-to-day practice. For every detail, see on www.diabetesdilemma.org, which is our website. You can watch all the past important programs which are for the last 5-6 years. Whatever next time we will be directly from this website. So do visit this website. Which are happening for last 5 years. Today we will discuss clinical aspects, what we claim what is the importance of this journal also was that discuss latest paper which is just published 2 months back. Silent conditions changes. That is the whole idea of saying this journal. Captured in traditional risk factors, which push these people towards very high cardiovascular risk. Let's meet this gentleman. He is a 42 years old Mr. Naveen. He is newly diagnosed, came with the diagnosis of type 2 diabetes with A1C of 10.5. And you can see fasting 156 and postprandial 250. BMI is 30, he is an obese person. His waist circumference is 105 centimeters, so he is obese with also lots of central obesity. He has a stressful job, he needs to travel a lot. His BP was 146/92. So standard patients which we routinely see in our clinics, which come to us with a diagnosis, he is just walking, talking, he is very busy. He has asked me 10 times, will you see me on the time because I am very busy. I want to go at work. So you give proper appointments and see these patients. All his lab is normal. His urine albumin creatinine ratio is 28 micrograms per milligram of creatinine. The plan, we know A1C target, which we assign to someone when such patient comes. We assign a blood pressure target like A, B, C, D, we call it. So A1C is, of course, for this young 42 years, my target is 6.5. And I want to reach 6.5 gently, not suddenly in a 1 month's time. So gentle reaching to that target is crucial and important. Then we need blood pressure targets, which is 130/80 by the latest FDA recommendations. LDL target we know we want below 100, but we can discuss among the discussions when our cardiologist expert will join in the discussion time today. Then we often forget weight management. Weight management is nowadays left to patient themselves or to these apps which are managing their weight, or maybe someone who is doing only weight management clinics. But we physicians in our clinic are very much not that much aggressive for weight management. We know that weight loss is very good, but what we are doing for that is the time to think today after today's program. And of course, choice of drugs are very, very important. That's how we are going to manage the risk, which again we will discuss. So he was treated with small dose of glimepiride, metformin, and after 5 months his A1C was very good, 7.4. He lost his weight because he was quite motivated. He never wanted diabetes. That label at this young age of 42, He has lots of career in front of him, doesn't want to tell anyone that I have diabetes. So he was extremely motivated. He lost weight, his BMI came down, his medicines reduced slowly. And then after about 6-7 months, he wanted to try lifestyle, diabetes reversal and some lifestyle. So he joined some app. And after 1 year, he was very fine, maintaining his A1C below 7 without any drugs. What happens to these individuals? Came to follow up after 2 years. Due to busy schedule, he was not able to meet doctor. His A1C was 11.5 this time. BMI he regained his weight, whatever he lost. He had some tingling numbness symptom, and his urine albumin creatine ratio now was 110 microgram because he stopped his blood pressure medicines as well. This is a routine story, and we see these patients every day in our clinics, so many of them. I have said 42, but we have patients 38, 35, 39, 45, and they just come. So his age is now 44. So we lost very important initial 2 years, 24 months in these patients' times with the bad glycemic legacy. So what I am going to discuss is this paper by Professor Naveed Sarkar, which was just published in Diabetes Care. So this was in 2024 in the month of March, and actually came in the paper edition as April. Very interesting paper. Actually, it's a review. So it's not exactly paper, it's a comparison of Naveed Sarkar. Naveed Sarkar is from Scotland, and he has very good kind of publications and basic understanding. So what he has done in this paper, that he has discussed whatever he has published in last 2-3 his main publications and created a very nice story. When you read it, you will realize. So whoever is attending today, I will send the paper on WhatsApp. Please go through it. It will be more interesting once we discuss about it. So what he says is that there is a weight gain in every individual. There is an upstream, and weight gain comes with central fat accumulation. This fat accumulation increases with age. We know sex, postmenopausal, there is a lot of weight gain, and ethnicity is crucial. So if you say someone Fiji Islanders, they will have BMI of 40-45. And if you say South Asians, our ethnicity, we will not be much obese, but we will be more adipose. So central fat accumulation will be much more according to the ethnicity. This we measure as abdominal circumference, and its abdominal circumference has a direct correlation with cardiovascular risk and kidney risk. So just measuring the simple abdominal, don't for even waist-hip ratio. There are lots of waist to height ratio, but simple abdominal circumference which we can do in our clinics is crucial to explain to the patient, though we know, okay, we know it must be above 100, but it is very important to explain to the patient that this is not good for you because there is so much of fat around the abdomen. So where is this fat? So there is a spillover. It's not only under the skin. This excess fat comes in pancreas, it comes in muscles, it comes around beta cells and around the major arteries, which is like aorta and all the major arteries. There is a fat around these vessels. I remember that Professor Ludkin was working with us many years back when I was in KM and very much active in research. There was a lot of his first papers he published was crosstalk of this fat which is outside the arteries, which has a direct crosstalk with the endothelium. And that the first streak which starts of atherosclerosis has a direct correlation with the fat which is there outside the arteries. So even this fat is spillover as fat. Along with this fat, what comes is that it gets spillover in the blood as well. So you get typical higher TG, low HDL, kind of raised hepatic enzymes, which gives us an idea of hepatic steatosis in some patients, maybe about 45. And some 48. That gives us an idea there is a lot of fat in the liver. And this is routine, like fatty liver on this one, so it gives us an alarm that there is so much of spillover. Along with this fat comes higher blood pressure. Because of increased intake of food, there is always high salt intake. And salt intake comes with a more vasocrine signaling. and there is a more vasoconstriction which leads to higher blood pressure. So usually these obesity or high intake is associated with high blood pressure, which we know 2 plus 2 is not 4 in type 2 diabetes, is 6 or 8 times the risk goes up. Very interesting papers I heard last year in EASD, that this epicardial fat, which I will like to discuss with Dr. Sinkar today, that this has a independent correlation with atrial fibrillation and heart failure mainly, especially in young type 2 diabetes, more the epicardial fat. And nowadays we have papers which say that SGLT2 inhibitors change this distribution of epicardial fat, which is direct measurements have shown that. So it is again crucial what drugs we choose to reduce this risk. So all these factors together, the HbA1c rises on the background, as we saw for this Mr. Naveen in last 2 years, which increase the cardiovascular risk. Now, whenever there is someone comes up type 2 diabetes, we say it's a CHD equivalent. So actually the CHD equivalent is someone who has a past AMI. So his risk is way higher than someone just plainly getting diagnosed. But how this risk comes, like suppose these are the pre-diabetes individuals, the risk is going up, then we treat, this treatment is now quite well established even in our country, statins, blood pressure, at least in where we are practicing, like in Maharashtra and Pune, they are quite aggressive treatment by all physicians, good statins, good blood pressure control, good oral drugs, even a good choice like SGLT2 inhibitors for such patients, so that this higher risk comes down. So this higher risk comes down because of this standard treatment. Now very interesting is these people. This is Mr. Naveen's story. So he got diagnosed, he was well controlled, but he became uncontrolled here. So we lost the major, and so he will reach this high risk much earlier, which could have been prevented by standard treatment. Even with standard treatment, we are reaching it quite as the age advancing and duration of diabetes is advancing. Duration of diabetes is also very important, which is not calculated in standard risk factors and the family history of cardiac problems. And also I am going to discuss few slides about age at diagnosis of type 2 diabetes. So this is bad glycemic legacy, and though we talk about microvascular complications, these individuals reach cardiac risk much faster if they have also adiposity and obesity. So that is important. Now, the most important part is the younger type 2 diabetes here. They have a very rapid increase in the risk of cardiac as well as CKD. As you have seen, just 2 years of hyperglycemia, his urinary albumin creatinine ratio increased from 28 to 110, which we see in our Indian patients rapidly progress. I will come to that in the next few slides. So, when we say CHD equivalent, not treating glucose for some time, not treating standard risk factors, and of course not considering at what age patient is diagnosed of type 2 diabetes is crucial to keep them below to the high CV risk. Weight loss is very important, and we have lot of studies published that intentional weight loss has good cardiovascular benefits. Look Ahead is, we have the published now, we have seen the publications of Look Ahead, which also says that intentional weight loss and trial weight loss will reduce this risk. Bariatric surgery patients have definitely reduced cardiac as well as kidney risk. There is a direct trial which was published, which is a remission of type 2 diabetes. It is also shows that CV risk goes down. We know any weight loss, there is again regain of weight after some time. So we are not discussing obesity management today, but just some weight loss which is so crucial. Now this is Naveed Sattar has discussed. This is very important. You can see there is a Swedish National Diabetes Registry, and it's very good from Sweden. From friend Naveed Sattar is there from Sweden, and it shows that association between BMI and LDL cholesterol. So on this upper panel, we are seeing acute myocardial infarction risk, and here this is BMI and this is LDL cholesterol. You can see as the LDL cholesterol goes up, the risk of AMI is steep rise. It's quite parallel steep rise as the LDL is going up. In the values, the cutoff here is 96. Just 96 of LDL. As it is going up, there is a risk of going up. These are actual patients from the registry. These are not clinical trials. So all the population. And you see BMI. If the BMI is going up, there is no correlation with AMI, acute myocardial infarction. But when it comes to heart failure, there is a very strong correlation with the BMI. As the BMI is going, and see the steepness of the rise of heart failure here. At least with LDL and AMI, there is slightly it is, but this is quite steep. So a slight increase in obesity or central obesity, the heart failure risk is going quite high. And these are a big population. They also have a lot of South Asian patients. In fact, he has written a separate paper for the minor population from this group who are South Asians. And LDL cholesterol doesn't need that correlation here, like which gets for heart failure. So when we talk about cardiovascular risk, we need to make them separate. AMI is separate, heart failure is separate, and of course the other cardiovascular risk. So we have done up till now quite good with the main focus on the glucose, non-HDL lipid management, good blood pressure and thrombolytic. We give aspirins and antiplatelet agents, and we definitely have good effect on accelerated atherogenosis nowadays. What we are not looking is this excess calorie surplus and ectopic fat. This is lacking in our day-to-day clinical practice. So which comes with all the hemodynamic consequences with that, which increase this kidney risk and heart failure, which lots of pathogenetic mechanisms are already published. These are the decreasing trends of coronary artery disease and AMI, and you can see that it's again from this Sweden, same registry which from David Sarkar has published. You can see it's coronary artery disease going down. The red ones are diabetics and blue are non-diabetics. It's going down as the years are going ahead. Like in 2017, it is much less than what it was in 2001 and 2. AMI is going down. Cerebrovascular disease, strokes are going down. You see heart failure, it's going down but then it's plateauing. It's not going down, and you can see the difference between the non-diabetic and diabetics. It's much higher, it is not coming down, even though we are treating traditionally blood pressure, A1C and the cholesterol as well as the good drugs. Still it is not coming down. So time to have an aggressive approach, which we will discuss. Changing patterns of the cause of death in our patients. Soon cancer may be the leading cause because cancer is correlated with obesity and hyperglycemia. Reduction, as even US data shows some reduction in cardiovascular events, and multiple chronic conditions arise. We know about non-alcoholic steatohepatitis, the names have changed, lots of dementia, and CKD is the major things. This was another, this paper was published quite a few years back, which he has again reviewed in his paper, that at what age someone is getting diagnosed as type 2 diabetes is very important. So someone is getting at the age of 62 and someone is getting at the 42. There is vast difference in the risk calculations. See the heart failure risk. It is almost, hazard ratio is 5 times higher than someone is getting who is getting diagnosed at the age above 50 or 60. So younger age of onset is not good. These are the young people who are getting type 2 diabetes diagnosed around 30 and 40 years of age. The blue is men and the red are women. So you see, women are more obese. And when you get diabetes diagnosed at a young age, they need to have more adiposity and obesity to get that beta cell dysfunction. So definitely they are more adipose, especially in India I will say adipose. The weight is higher of these young patients when they get diagnosed as diabetes. They have a higher systolic blood pressure compared to someone who is getting diagnosed at 60 and 70. That is, these graphs are comparing age at diagnosis. Triglycerides are higher, and even usually they come with high A1C, 11, 10.5. They will never come with 7.5 A1C. The group which we are treating in India. So these drugs which we are treating, GLP-1 receptor agonist, we are saying use them early. I think next few months we will get generics of semaglutide, which is coming. And even at present, those who can afford, we should use these drugs in the early few years of type 2 diabetes. So this mechanism we have already discussed. I think when we will listen the heart failure, so I am not going into details of that. But there is something which was a new, this is very nicely explained that there are some molecular changes because of SGLT2 inhibitor. It creates a energy deprivation kind of a situation in every cell. So the cells fight kind of a thing, and they have some effect of cellular repair mechanism because it creates a kind of energy deprivation, and this is also one of the very important mechanisms which improve the individual myocardial cell health and also individual nephron health. Other details we will discuss, and Dr. Simkar will be discussing about heart failure in particular. Now coming to these young individuals in our clinics, they are South Asians. Onset of diabetes is a decade or more earlier, I will say it's more. Onset of MI is 10 years earlier in our patients, which we know from epidemiological studies. Faster ectopic fat gain for a given BMI, that we all are aware and we are seeing it. More rapid beta cell deterioration. Like someone comes and like there is no stage of impaired glucose tolerance in our patient, and more rapid even glycemic deterioration for these young patients. So there are very good papers which show that how IGT gets transferred to type 2 diabetes. If you see white Caucasian population, they take 5 to 6 years. Chinese DRAGKING study showed 7 years. But Indian Diabetes Prevention Program done by Professor Ramchandran showed only 2 years. And there are individuals, there is no stage of IGT. They are normal, just high risk, more adiposity, more stress, and they jump to frank type 2 diabetes. So there is very less time to do so-called prevention of frank diabetes in our individuals. And something like adiposity or pregnancy for young girls happens, they get fast forward to frank diabetes. Once they get diabetes, there is a very rapid deterioration, and we see with frank proteinuria in just 5 to 6 years. So that is also one needs to be aware. Like this individual, Mr. Nagin, no one should allow them to go to these programs for simple lifestyles. And it is our responsibility to explain that drugs are important. Don't stop completely, and a follow-up. So here again we need to use more digital medium for such patients for follow-up. What is genetic studies are showing? Just I am not going into details. The genetic polymorphism decides hyperglycemia, but there is a separate genetic polymorphism which decides kidney risk and cardiovascular risk, which comes to obesity. And that has been shown. This paper was published many years back when I was a part of Dr. Lajnik's team at KM. Like FTO gene variant was strongly associated with type 2 diabetes in South Asia. The same cohort, I think 700 patients were from our clinic, young patients who got diagnosed as type 2 diabetes. The second paper is published presently, which shows that these people have the genetic polymorphism is mediated through BMI and not through hyperglycemia and adiposity. Now, type 2 diabetes has 5 types, which we all are aware now because of these clusters in type 2 diabetes as described. The names are a bit difficult to remember or to explain. I just say there are LADA type of patients, young, they are positive, get diagnosed, very thin, come with very severe hyperglycemia. This is kind of autoimmune. Then we get severe insulin deficient diabetes, like thin, low BMI, 11, 12, and they need insulin quite fast, 1 or 2 years. Then there are severe insulin resistance, so they do have a lot of resistance, they have adiposity, obesity, and then those who get late diagnosis like 60 years. So SIDD is more predominant in Indian population from this study, which was the same cohort which I was talking about, like many patients are from Nigeria. So this SIDD is more predominant, like insulin deficient patients as well as insulin resistance. So we see a lot of these young patients who are not thin, but they are more adipose, obese, but they are deficient. So they come with very high A1C, they progress very fast, though they are not thin. So we need to change our thinking that even these obese or adipose individuals are actually insulin deficient. If we do calculate their HOMA IR and HOMA beta right at diagnosis, we will get some idea. And this group has an extreme high risk of heart failure as well as chronic kidney disease, creating proteinuria or albuminuria. So whenever we see a newly diagnosed patient who is diagnosed at a young age and adipose and obese, if he falls into this, Dr. Mohan has described the group combined insulin resistant and combined insulin deficiency, which I am talking about, like Mr. Naveen. He doesn't have only insulin resistance of obesity, he also has severe insulin deficiency. That's why he got 11 A1C when he got diagnosed, and also he progressed very fast. So this is a sign, these are the combined IR plus insulin deficiency plus resistance, and these are the patients who will look for chronic kidney disease and heart failure. We have marvelous drugs, very good way to diagnose them early, and we can prevent someone reaching end-stage kidney disease if we use correct so many drugs. So in India, we call it as a poor country, but it's a poor country with many rich people, but no one wants to spend their own money for their own medications. But we are lucky to have good Indian pharmaceutical companies which are coming with generic medicines, I think before the patents got over. I remember the debate when first time dapagliflozin came out of patent, and WHO actually published that so much of advantage it is offering. It was called as NPA licensing that time, and there was so much of advantage. These drugs are coming cheaper, so many life years are being added to the patients, and that's why I think in the court, Astra people will know better than me. But then that was a good kind of a thing, and we are really lucky in India. If you see doctors and the patients from other countries, even simple drugs, even like UK, they do not have these very good drugs at a cheap rate. So though we know originals, maybe some salt difference, but at least those who can't afford, there is something which we can give them. So early diagnosis is important. Focus to, of course, we are very experts in treating the standard risk, but focus to treat adiposity even prior to diagnosis. Major lifestyle change. I include myself into that. We also think we are doctors and we just treat the problems, but I think we all should incorporate lifestyle changes, kind of a practice in our clinics, and of course we have good drugs. So considerable evidence has come from clinical, epidemiological, trends in complication, genetic studies, and the treatment effects that excess weight we need to target along with treating our standard whatever treatment which we give for type 2 diabetes. So this was the paper, and it's a very good read. Whoever is present, we will send you the whole paper on the WhatsApp. You please download and you go through it. It's really nice, and the language is very nice, typical from UK and Scandinavian countries. Simple to read. So I welcome Dr. Amit Sinkar before we go to the discussion. Dr. Amit Sinkar is cardiologist, and he is our expert today for all the question answers. You have to come from this side. And he's completed his primary DNB, and he is working in NMRD Institute, and also is his private clinic. He is an interventional cardiologist for the last 13 years. Special interest in preventive cardiology. So good you are here today. And special interest in heart failure and cardiac rehabilitation. So I am sure our discussion will go much interesting. Just a small thing. Our kidney expert Dr. Morkhardikar today, he couldn't come because there was some complications for his transplant case. And when I told him just don't worry, he was very relaxed. He was getting stressed out how to say no. So we will be discussing mainly the cardiovascular risk today. So yes, Amit, please.
Good evening, friends. Thank you, Shailaja ma'am, for inviting me for this talk today. So, as ma'am has already discussed about a typical metabolic syndrome patient that we see in our day-to-day clinics. So, my talk for today is about something about usage of SGLT2 inhibitors in heart failure across all spectrum of ejection fraction. We all know that once a diabetic, always a diabetic, once a hypertensive, always a hypertensive. Similarly, any heart failure patient, once diagnosed, is going to be a heart failure patient for lifelong, and is going to move around the spectrum of ejection fraction from reduced ejection fraction to mid-range ejection fraction to preserved ejection fraction, and vice versa. We have been targeting our patients mostly with heart failure with reduced ejection fraction till today. Why? Because we considered those patients to have higher mortality, higher hospital admissions, and we had better drugs to treat them. We had completely neglected heart failure with preserved ejection fraction till today, probably because we thought that these patients may not be having higher mortality or hospital admissions, or more or less, even if we diagnose them, we didn't add specific drugs to treat them. And that's why it was very much neglected till recently, where data has given us sufficient evidence that there are good drugs which can actually have better outcomes even with heart failure with preserved ejection fraction. So let me start with few basics about heart failure terminologies which are present today. Heart failure is now divided into three different types. One is, as you all know, is heart failure with reduced ejection fraction or HFrEF, where conventionally the patient with typical signs and symptoms of heart failure will have an ejection fraction of less than 40%. Then there is the other extreme with patients of signs and symptoms of heart failure, but on an echo we find an ejection fraction of more than 50% or even sometimes more than 60%. And there is a mid-range variety where the EF falls between 40 to 50. These are usually patients who are either in a worsening condition, maybe have recently suffered from an acute coronary syndrome, or they are improving from HFrEF towards HFpEF. So there are few factors which are associated with either clinical progression or worsening in these patients. Factors associated with good recovery are patients having heart failure in a younger age group, in females, those who presented with a lower heart failure severity, shorter heart failure duration, or having fewer comorbidities. On the other hand, those patients who are likely to worsen from HFpEF to HFrEF would be those having mainly major comorbidities like diabetes, presence of coronary artery disease, lack of specialized heart failure follow, and higher anti-proBNP levels. Surprisingly, if we look at the data for hospital readmissions or all-cause readmissions, or even for that matter all-cause death, and we compare the three types of heart failure, we can see that the heart failure readmissions are close to 50% in HFrEF patients, but even in HFpEF patients, the incidence is about almost 40%. So that's quite high. Previously, we thought that these patients may not need recurrent hospitalizations, but even in HFpEF and heart failure with mid-range, the heart failure readmission rates are close to 40 to 45%. Similarly, all-cause readmission rates are also almost equivalent. And if you look at the all-cause death, that is a big surprise that even the mortality statistics are similar in mid-range and preserved ejection fraction as compared to reduced ejection fraction. So we definitely can't neglect our heart failure patients who have an ejection fraction of more than 40%. And that's why nowadays we say that any heart failure is having equal chances of hospital readmissions or cardiovascular mortality irrespective of ejection fraction. So once a heart failure is diagnosed, forget about looking at the ejection fraction, treat him with all possible medications, lifestyle interventions, and correction of comorbidities. So in the earlier decades, the prevalence of heart failure with preserved ejection fraction was low, but if you look at the current data, the prevalence rates of HFpEF are gradually rising. Now it doesn't mean that HFrEF is reducing and HFpEF is rising, but out of suppose 100 patients of heart failure are being looked into, the prevalence of HFpEF amongst the heart failure patients is increasing, even though the absolute numbers are increasing in all categories. So the reasons for this could be obviously the rapidly aging global population because of better treatment availabilities and more incidence of comorbidities like diabetes, hypertension and obesity. That's why the incidence and prevalence of HFpEF is also rising. We all know that the heart failure is also divided into 4 different stages. Technically stage A, even if by definition they are not actually heart failure patients, but they are actually at higher risk of developing HF in future. They would be considered as those having diabetes, hypertension, dyslipidemia, a positive family history of heart disease and heart failure. Also stage B, wherein there is onset of structural heart disease, like the presence of first acute coronary syndrome, but still they may not be having symptoms or signs of heart failure. Now these are the 2 stages where actually preventive therapies can be initiated so as to prevent these patients from progressing to stage C or stage T heart failure. Stage C is where the patients are symptomatic either previously or ongoing symptoms of heart failure along with presence of structural and or functional heart disease. And lastly, refractory heart failure where they need specialized treatments like interventions or need recurrent hospitalizations. But with every hospitalization after stage B, these patients keep on worsening in terms of recurrence of symptoms as well as increase in the mortality and reduction in the quality of life. The mortality risk in heart failure is an urgent basis. That's why we can see that in-hospital mortality in HF patients is very high after acute decompensation. And as time progresses over a period of 5 years, almost 50% of the patients are likely to succumb from heart failure. Now, goals of therapy in heart failure are mainly 3 aims. One is obviously reduction in mortality. Second is prevention of recurrent hospitalizations due to worsening of heart failure. And lastly, but from patient's perspective, this is the most important, that is improvement in clinical status, the functional capacity and quality of life. So what do the guidelines recommend? The ESC 2021 heart failure guidelines suggested that SGLT2 inhibitors is one of the important treatments amongst others including beta blocker, ACE or ARNI, MRA and loop diuretic for fluid retention. The recent 2022 NCCN guidelines suggested again SGLT2 inhibitor as one of the 4 pillars amongst the other 4 pillars in the treatment of HFrEF. This we are talking of mainly heart failure with reduced ejection fraction. The 2023 AC guidelines for HFpEF were published for the first time. There was a guideline-directed medical therapy for heart failure with preserved ejection fraction. Till now, the guidelines didn't recommend any class 1 therapy for HFpEF, but this was the first time when after SGLT2 trials we have sufficient evidence that SGLT2 trials can be considered as a class 1A indication, and that's the only drug which is indicated with the class 1A level in the treatment of HFpEF patients. Even in the 2020 ESC update, it was shown that diabetics and SGLT2 inhibitors were the only class of drugs which should and can be given in all HFpEF patients. Beyond that, the other class of drugs like ARNI, MRA and beta blocker may be considered with a class 2B indication in such patients. So how does actually SGLT2 inhibitor patients help in our heart failure patients? So as ma'am showed one of the slides wherein it was shown that SGLT2 inhibitors does help in reducing the interstitial fluid volume. and that is one of the most important aspects where it helps when SGLT2 inhibitors are started during the index hospitalization of heart failure. So technically it can help in reducing the early pulmonary edema in ADHF patients where we are not able to initiate other goal-directed medical therapies, but SGLT2 inhibitor can be started immediately after admission for heart failure, and probably one of the mechanisms where it helps in that stage is by reduction in the interstitial fluid volume. Apart from that, it also helps in the long term with amelioration of endothelial dysfunction, decreased oxidative stress, downregulation of systemic inflammation. It improves heart pump energetics. Another possible way of improvement in the early stages, reduce sympathetic activity, increase diuresis. By inhibition of sodium hydrogen exchange, it also causes increased erythropoietin production, and with all of that, in the long run, it will help in amelioration of organ damage induced by heart failure, CKD, CVD, as well as infections, and ultimately will lead to improved survival, which has also been clearly shown in evidence by improved CV deaths and mortality in all heart failure patients. So, what is the evidence with DAPA to support these guideline recommendations? There were mainly two trials. One was the DAPA-HF trial for FF patients and the DELIVER trial for FF patients. In Paradigm HF as well as DAPA-HF, it was shown that when SGLT2 was initiated along with the other goal-directed medical therapies as an add-on drug, the first three drugs, it had showed improved survival and other benefits as compared to the three drugs alone. So this was the DAPA-HF trial where mainly the heart failure with reduced ejection fraction having an EF of less than 40% were included, and it was combined in a 1:1 randomization against placebo. So if you look at the statistics, there was a statistical difference as compared to the placebo right from day 28 after its initiation, and it showed a significant 26% relative risk reduction in CV death or worsening of heart failure. This was the pattern that I was talking, that when SGLT2 is added to the other three drugs like ARNI, beta blocker and MRA, it showed a significant drastic improvement in CV mortality as well as HF hospitalizations. So this was again new breakthrough in the management of FF, where conventionally only ACE-ARBs or beta blockers were used initially. So these are the various trials of SGLT2 inhibitors which had showed a significant impact in heart failure patients. Then came the DELIVER trial where heart failure with preserved ejection fraction patients were included. Again, the DAPA was compared against placebo. The primary endpoint was the time to first occurrence of any composite of CV death or worsening heart failure patients. This was again a multi-center randomized control trial. The patients were quite sick, even older patients up to 72 years were included in this patient. There were a lot of comorbidities associated, including diabetes, obesity, hypertension, and coronary artery disease. Again, here you can see that in fact usage of dapagliflozin showed statistically significant results with starting and the results as early as day 13. In HFrEF, the results were seen as early as day 28, but in HFpEF, the results were seen as early as day 13 of initiation. And again, there was an 18% relative risk reduction in the composite endpoints as compared to placebo. Now, if you look at the various subgroups, irrespective of the ethnicity, age, or the comorbidities, everywhere DAPA showed to be superior as compared to placebo when conventional standard of care was used in all these patients. Again, if you look at the safety outcomes, the adverse effects were similar in both the groups. So, evidence of DAPA across the full EF range using pooled analysis of DAPA-HF and DELIVER was also published. the purpose of this particular analysis was to examine the effect of DAPA across all spectrum of LVEF, given the attenuation seen in patients with higher LVEF in other HF medication trials. For example, in empagliflozin, it was shown that when the ejection fraction was more than 60%, they apparently could not show mortality benefits. But whereas in DELIVER trial, that particular deviation was also addressed, and even in those patients who had typically AF of more than 60%, despite having heart failure symptoms or elevated DNP, DAPA showed a significant improvement in CV mortality especially. So this was the combined effect of DAPA-HF and DELIVER together. What DELIVER adds to the FF management compared to other SGLT2 inhibitors, as we said, that in those patients having AF of more than 60%, the total hospitalization for heart failure and CV deaths were still better in DAPA as compared to placebo, but in EMPA somehow failed to show that benefit when the AF was above 60%. I'll skip through these statistical slides. Again, there was another trial with heart failure with improved ejection fraction. This was something new terminology, where patients who were initially in the FF category and with appropriate treatment improved to a better ejection fraction, and now they were above 40%. Then they were called as heart failure with improved ejection fraction. Even in such patients, it was shown that continuation of the 4 pillars of GDMT, including SGLT2, would definitely help in reduction in recurrent heart failure hospitalizations and also mortality. Now, this particular analysis was specific to SGLT2 inhibitors, where those patients who improved AF to more than 40%, continuation of SGLT2 inhibitors in these patients also showed significant improvement as compared to stopping SGLT2 inhibitors in the long run. Now, this particular analysis was SGLT2 inhibitors, where those patients who improved AF to more than 40%, so to summarize, mortality was significant in DAPA-HF as well as the DELIVER pooled analysis, and it covered the entire spectrum and showed that CV death as well as heart failure hospitalizations does reduce significantly as against placebo. Again, this was not a head-to-head comparison with EMPA, but if we compare the different trials against placebo, then different trials would show different outcomes. But ultimately what we need to understand is that in all heart failure spectrum patients, irrespective of ejection fraction, we should initiate and continue SGLT2 inhibitors as long as the patients can take it. So the advantages of SGLT2 inhibitors are it is a single dose, no dose titration is needed, one pill once per day, substantially improves survival as well as prevents hospitalization, meaningfully improves the quality of life as well as functional status. The benefits appear rapidly within 18 to 28 days of initiation, exceptionally well tolerated and safe, does not lower blood pressure or does so very minimally, hence very safe again to give in acute heart failure patients, no adverse renal effects, and instead preserves kidney function and prevents dialysis in worsening kidney failure patients. So again, the debate with original versus generic continues, but I usually give options to my patients. This is the imported original medication versus the available generics. Those who can afford definitely should use the original one, because in my experience I have found to give it better weight control as well as A1C reduction as against generics. But for those who can't afford, something is definitely better than nothing. Hence we shouldn't divide them from using generics instead of not using anything. So with that I would stop my talk over here. We can have the
Simple, can you dilate on the topic of not all SGLT2 are similar? SG attributes are similar in treatment of FF or FF. So that slide was important, but it was not.
In FF specifically, in FF when the ejection fraction was more than 60%. Now, FF is considered as anything more than 50%. But 50 to 60 versus more than 60, this division has not been particularly studied in majority of the trials. But Emperor Reg, where empagliflozin was used, and Deliver, where dapagliflozin was used. And in both the trials, those patients got an ejection fraction of more than 60%. Not only more than 50, but more than 60%. In this particular subgroup, the mortality benefits were seen only with dapagliflozin and somehow not with empagliflozin. So more than 50 is not same as more than 60. Those patients who had more than 60% DF probably benefited better with dapa as against empagliflozin.
I think in the initial trials showed quite separation, but I think now with the heart failure, reservation, tracks, I think all
Eventually everything would merge together, but that was one particular trial that showed it.
Shall we conclude from that only one trial that Impa is inferior to DAPA?
No, I don't think so. We should be using it as a class effect. One particular trial shouldn't skew our decisions to use either Empa or DAPA.
any trial results, we should interpret what are the patient population which is recruited in that trial. So the basic difference in all empagliflozin trials and empagliflozin trials was done by cardiologists. So the patients recruited are very high risk. If you see the event rate in the control group of theirs, which was non-empa, is extremely high. So the difference was not there. So all empa, because that group is LTV group. And dapagliflozin trials, right from the first trial, are done in the mainly diabetes clinics. So the patients recruited are not that high risk as empagliflozin trials. So that's why dapa again came with the special trials with the high risk group. So just to prove that it's also good in low ejection fraction patients. Because initially that advantage was only for deliver. So every trial, not patient group, and that's why our confidence comes to use that molecule in that particular group of patients, because we have the confidence. So many patients were 5,000, 10,000 patients were treated with this molecule with this dose. So
The effect of Impa is seen more in post-MI patients
it is same.
Not specifically post-evaluation.
because that the Impa trial was mainly dealing with these patients.
No, it was just high CV risk.
High severe.
For every particular trial, the inclusion criteria, there would be 1 or 2 points here and there which are not there in other trials. It would be really very difficult to memorize all the inclusion criteria for all individual trials. We should look at it as a
No, as a cardiologist, what will be your choice for post-MI failures?
post-MI failure. I can use both EMPA and DAPA. No specific preference for EMPA, just for post-MI.
I think now with so much of evidence for every molecule, at least these two, which we are using EMPA and DAPA, in all the subgroup of patients, reserved, low ejection fraction, or normal patients, the evidence is same. Initially, this discussion was there about 4 years, 3 years back, when these trials were not published. Now both are almost same, because both have now good evidence from all types of patients.
Intention is not to differentiate between EMPA versus DAPA. The intention is to start using SGLT2 inhibitors for all HF patients.
Now there is one more confusion I always see in patients with the dose, 10 mg and 25 mg for EMPA. DAPA is quite clear cut. So I think all the, when we are using for cardiovascular benefit or kidney benefit, the dose is standard 10 mg, which was used in all the trials. Issue comes with empagliflozin, which use 25 mg sometimes, which gives slightly better results for A1C, very slight. For cardiovascular benefit or kidney benefit, the dose is standard 10 mg, which was used in all the trials. Now this patient which I discussed, Mr. have so many patients in our laboratories for diabetes. Like what we do screening. So guidelines says that treadmill test is a must. They don't say it. But because the big trials have shown that whether you do it or you don't do it, you cannot predict the risk. So what is your advice in the particular patients? What should we do as a routine cardiac screening other than traditional screening about these imagings, stress test? When should we do a coronary artery patients? Then we will discuss about it.
Basic ECG and 2D proper 2D including diastolic indices is a must for all these patients having risk factors for developing cardiovascular disease. Now, those patients who are not having any anginal symptoms, there is no recommendation for doing any stress test or for that matter even CT coronary angiogram per se. But coronary artery calcium score, yes, definitely it has shown some independent risk prediction as compared to not doing it absolutely. So coronary calcium score definitely can be added as a risk predictor in those having other risk factors for developing CVD. As far as stress test is concerned, its accuracy I would say is just 70 to 80% with both false positive and false negatives. So as a screening test, apparently without any symptoms of angina may not be recommended because it's likely to give us false results.
But I think, does it change with the duration of diabetes? Because patients with 10, 15, 20 years of diabetes, we see them often coming with acute events. And if they haven't done stress test, then for that treating doctor, you can't go by statistics.
So what I would say is we should do a stress test. If it's positive, that will help us in diagnosing the disease earlier. But if it is negative, does not technically rule out coronary artery disease. So it can only help us in predicting a positive outcome based on the symptoms or the other risk factors. But a negative stress test will not rule out coronary artery disease.
But we can do coronary artery calcium scores for each and every. What about CT angio? Should we use this routinely?
CT coronary angio again has got a good negative predictive value of about 95%, meaning a normal CT CAG would be actually normal on a conventional angio, but a CT CAG showing some abnormality in the form of plaques or blockages has to be confirmed on a conventional angiography because again the positive predictive value of CT CAG is low at around 60%. So CT-CAG as a screening test is not recommended, but for someone who has got very high risk factors and really wishes to rule out coronary artery disease, especially if the family if someone had a sudden cardiac arrest or a sudden myocardial infarction without any past risk factor history, and the family member or the son of the patient wants to know whether he has the risk of developing such similar sudden cardiac arrest. In such scenario, probably I would recommend a CT coronary angiography because a routine echo or stress test is unlikely to rule coronary artery disease in this patient. But for negating or for ruling out coronary artery disease, for those who would be at high risk, especially with the positive families, then in such patients CT-CAG would be a good choice. But without any family history, without any risk factors, just for the sake of screening, CT-CAG is not a good test. In such scenarios, CT coronary calcium score would be good enough to predict the risk.
Because when we say ASCVD yes, then it's clear. When we say ASCVD no, there is a big spectrum of patient. There is something like Mr. Nagin which I presented with almost more negligible risk. But at the same time, there is someone who has 12 years of diabetes, age and other risk factors like family history. Then I think in such patients you are saying at the higher end of spectrum, we can advise CT angio.
CT-CAG doesn't diagnose diffuse disease, is it?
So that's why the positive predictive value is very low.
Because diffuse disease is very common in diabetes.
Yes, yes. So that's why CT-CAG for diagnosis of CAD, the outcomes are very poor. It is mainly for ruling it out.
So gold standard is still
Conventional angiography.
Yes.
Hi. My question is a little off topic. But is there a difference in risk of UTIs between DAPA and empagliflozin?
Gold standard
All trials have shown the similar kind of an incidence about fungal infections. They are similar. So, radonitis and vaginitis, they are same across the trials on all three molecules. There is no difference. The urinary tract infection incidence depends on patient's problems. Like there are patients who get recurrent UTI. Mainly what we see in elderly women, if there is a post-mortem residue, or in patients with prostate in men, or maybe some calculi patients. If they have UTI, they will get recurrent UTI more. And if there is a recurrent UTI, these molecules can induce a non-ketosis.
So we should stop.
We should use it carefully. It's not a contraindication, but we have seen patients going in diabetic ketoacidosis, especially in women with recurrent urinary tract infections. Suppose someone got admitted with pyelonephritis and discharged. The patient is on SGLT2 inhibitor. It's better to avoid for some time unless it's clear. Otherwise, the patient will get a DP.
I would just re-put it, even if you stop it because of the acute genital urinary infection, after the urinary infection is being treated completely, you should restart SGLT2 inhibitor.
It's not a contraindication.
It's not that one stopped and always stopped, it shouldn't be
And
that.
at least one should be aware that because the patient just keep on taking, get admitted somewhere else. So we need to experiment these high-risk cases. We need to mark and have some good follow-up with.
Especially we need to re-educate the patient about the possibility of GUT, why it happened in the first place when the patient was on SGLT2 inhibitor. All those corrective measures need to be taken so that there is no recurrence of GUT in this.
Yeah, so that's fungal infections.
Right.
He's talking about urosepsis and urinary tract infections.
You see more cases of sarcopenia with
So
because we see
there are
aging
publications.
population, you see more sarcopenia.
Yes.
And they have to
I
take-
agree with this. There are lot of papers published about sarcopenia with SGLT2 inhibitors. First, see any weight loss, even with lifestyle changes, any weight loss, whether it's GLP-1 analog or any trial or lifestyle changes, any dietary changes, 35% is muscle loss. So whatever weight loss is there, 35% someone will lose muscle with any weight loss. With SGLT2 inhibitors particularly, there is some sarcopenia which has been discussed. Only thing is, this sarcopenia doesn't have any ill effects about the outcomes. The good effects of SGLT2 inhibitor are still there. But you definitely see, and clinically we see more because we see a lot of thin population. So patient come back and they say, I don't like this. I don't want this molecule because everyone is asking me. Now, whether it is deleterious and it should be not be used is it's not, all recommendations are you should use it even in thin patients because it has proved its benefits beyond doubt. But there is some sarcopenia which I have gone through a lot of papers about. There is some. So in some patients, occasionally, someone losing too much of weight, we do, all of us have such patients, we may have to stop SGLT inhibitors. Unless someone has heart failure, then of course we treat, or someone has CKD. But who do not have, like, there is no proteinuria, there is no heart failure, in such patients we may stop.
That can be overcome by promoting muscle building exercises with
Exactly. So muscle strengthening exercises we tell to each and every one. And especially patients who don't like it, sometimes we combine it with insurance, basal insurance, which again helps for some kind of a weight gain.
I wrote a standalone paper where resistance training was combined with SGLT2 inhibitors and that helped in reducing the sarcopenia. So definitely we can advise resistance training for all patients taking SGLT2 inhibitors.
epicardial fats are okay. It is also reduced by SGLT2. Is there any evidence?
Yeah, there is a very good.
There are many papers which are coming up which have shown that SGLT2 inhibitors
Because
does.
in X-ray chest also we see lot of epicardial fat in obese patients.
Usually it's diagnosed with MRI.
Yes, cardiac MRI is a gold standard for diagnosing the severity of epicardial fat, and all the SGLT2 trials were documented reduction in epicardial fat and used cardiac MRI techniques. And logically it seems that probably, even though epicardial fat is one of the markers of fat leading to more atherosclerosis, but in some way probably must also be responsible for the FF category of patients, and reduction in this epicardial fat probably improves the myocardial relaxation. That's how also it must be helping in reversing the remodeling associated with FF patients. So SGLT2 definitely helps in reduction in epicardial fat and indirectly in improvement in the FF category of patients.
There is one more confusion about the elderly patients and the use of SGLT2 inhibitors. And there is a recent last year's ASC, there was a very good papers published from the FDA. So FDA just combined all the data, and when they say elderly, it's above 85 in US population. And they showed no increase in any kind of a side effect just because of the age. So that typical thinking that this molecule can I use someone who is 75, if there is a role to play for prevention of a lot of things, we should use it rather treating like heart failure cases. So age, there is slight increase in the postural symptoms, dizziness.
In fact, I would put it other way, higher the risk in the elderly, the better would be the consequences of using SGLT2 inhibitors.
Because I come across a lot of patients where they are told by other doctors that don't use this, and when we push for SGLT2 inhibitors, someone advises not to use this just because of age. That has been, we are using it.
No, but we have to modify the dose of antihypertensive drugs when they are put on SGLT2.
Yes, because it does cause lowering of blood pressure to some extent, and also fluid loss because of diuresis. They are likely to get dehydrated, and that can precipitate further postural hypertension.
What is that FTO gene? FTO gene.
So which I showed the paper. So TCF792 polymorphism is very well established, and FTO is another polymorphism which is very well established. FTO in white Caucasian population doesn't show correlation.
But what is FTO?
It's a genetic polymorphism. So there are different polymorphisms in the genes which say that this population is more prone for these diseases. So one of that is this.
DSM triad applies everywhere, the agent, host and the environment. So unless all three together come up, the occurrence of the disease won't happen.
Exactly.
Even if someone who is genetically predisposed, if you can control the other two factors, then still the disease progression can be delayed.
That was seen very nicely in American diabetes prevention programs. Those who had a genetic polymorphism for type 2 diabetes, still they responded very well to the lifestyle intervention to prevent or postpone diabetes.
That can be projected in our Indian patients also.
Yeah, if you do genetic studies.
Young diabetics and diabetes. Young diabetes, usually a lot of young diabetes.
Yes.
Yeah,
Yeah, actually I said that when I was saying. So
Less than 45 years, diabetic patient no any other comorbid factor, probably if normal cholesterol levels, statins won't be recommended.
high
Any-
cholesterol.
Sorry.
They should come with
Ideal.
Then definitely statin is recommended. Irrespective of diabetes, patient with dyslipidemia or high cholesterol should be taking statin.
but suppose someone has a LDL of 78.
Yeah, that's what I was going to know. What do you mean by high cholesterol? We are looking at LDL targets. So for any normal person, we would expect LDL to be less than 130. For a diabetic, probably it would be less than 100. And with any additional risk factor like presence of CAD or other comorbidity, then maybe the LDL target should be much lower.
That is secondary prevention, below 70. But like routine type 2 diabetes, LDL has to be below 100. And then will you treat with statins such patient for primary prevention?
Diabetic patient with LDL more than 100?
No, below 100.
Below 100, if the diabetic patient is more than 45 years, then yes. If the patient is less than 45 years, then may not be.
This age thing which when we discuss about study risk, I know the standard guidelines, but in India we see so much of patients at 40 and 30 and
Exactly.
45.
if the LDL is less than 100,
Then
then the
see,
usage
all
of
the primary prevention trials show
In fact, they are
helps.
very high.
So this, I don't know, so.
then I would add CRP to the patient. If the HSCRP is more than 2, then as per Jupiter trial. Yes.
See the other things in the reports. Because this debate always comes and when we are talking about so much of young infants, diabetes getting diagnosed at the age of 35. So that person becomes 40, the diabetes is already 5 years old. And though LDL is say suppose 96. So by definition it's below 100, but filter adiposity, tubular awareness, all these factors come into very high risk.
We have seen young infarcts even with LDLs of less than 70, even without or with statins. So whether giving statins is going to reduce the incidence of an infarct is
This is
still
a
not
question.
sure.
What about this lipoprotein little?
LPA will just give us about the genetic risk of the
Should we
patient.
do it each year?
Yes. Because once in a lifetime everyone should have a LPA along with the lipid profile. That will give us the genetic risk of developing atherosclerosis in the future.
Not all these actually papers, it's not only LDL cholesterol. If you go to the open again studies, the registry shows it's LDL cholesterol continuous risk everyone knows, but what he was saying, inflammation to say HSCRP, we can just calculate remnant cholesterol. So total cholesterol and remove HDL and LDL from that, whatever remains, the target is 30. So that remnant cholesterol is high, it's better to give statin or non-HDL cholesterol, which we are calculating. So that also gives a good idea whether I should use statin. It's not only for pretty triglycerides. We use all these things. Someone is like 42, 43 years old and LDL is 96. But if the non-HDL is high or remnant cholesterols are high, we definitely use statin in such patients.
Regarding LDL assay, the best way is to ask for a direct LDL assay. Not all labs are doing LDL assays, most of them are giving calculated reports. And there could be a lot of fallacies depending upon the patient is really fasting or not fasting, we are not sure. Then the calculated LDLs are likely to be fallacious. Most of the trials where the LDL assays were used as treatment targets, everyone had studied direct LDL levels. So ideally it should be a non-fasting lipid profile with direct LDL assay. That's the best way to look at the lipids in today's world.
That's correct. And mainly in type 2 diabetes with high triglycerides and more VLDL values, especially when we do anti-lipid defense. It's very important to see the direct LDL.
Now that fasting, this lipid profile is out of certain.
Only if the
All
triglycerides
these
are
labs are not, they are insisting for.
So they don't, they still
They are not
do
educated.
they will ask someone to come fasting. So we have taken lots of CMEs, lots of papers. It doesn't include.
How are you addressing LPA levels, high LPA?
Presently only PCSK9 inhibitors are shown to reduce the LPA levels. None of the statins will lower the LPA.
Bempedoic acid, does it?
Not much effect. And technically we are not supposed to keep on repeating LPA levels. It is just a one-time marker to know the genetic risk. It has not been shown that reducing LPA levels is going to reduce the CV.
But it's a high risk marker.
Yes, it's only a high risk marker.
Markers.
It's a bystander telling us that this patient is at high risk and needs to be evaluated.
Do more sick angels, do like angels.
So many of my patients are complaining of cognitive dysfunction who are on statins, high intensity statin. So, are there any papers on whether they are progressing towards dementia or are there the only effects of bad effects of statin?
We need to look at other confounding factors which could be leading to that dementia, especially microvascular disease in the cerebral areas. So may not be attributable only
Are
to
there any studies of statin-induced cognitive dysfunction?
There are studies, but the incidence of cognitive dysfunction is very less. And if you look at the positive effect of statins, they are much higher as against the negative effects of cognitive dysfunction.
So it outweighs that little risk of cognitive
The
dysfunction.
benefits outweigh the risk of cognitive
And
dysfunction.
this cognitive dysfunction is not only with statins, it's usually long-standing diseases like type 2 diabetes and even other drugs. There is a very recent, very good paper which discusses this issue about all the chronic disease management drugs. Are they pushing our patients towards more cognitive dysfunction? The drugs. So, we cannot say it's only because of statins.
There was an interaction with the senior neuroclinician, and he first asked the patients which statin you are on and which dose you are on, in cases of progressive dementia.
Anecdotal examples we can discuss as a guidelines.
No,
At the
that's
same
right,
time,
but-
at the same time, though guidelines say every time we have to indigenize. So sometimes we do have to follow certain like these cognitive dysfunction issues, and we may not be using statins.
There are no studies which have shown that stopping statins have improved the cognitive dysfunction.
Hello. Do we need to monitor the glycosuria due to SGLT2 inhibitors?
You don't want
Only
it. Just tell
infection.
the patients, it will be there.
To educate the patients, because suddenly they say that my urine sugar was normal for these many days, suddenly I started showing sugar in the urine. That they consider as worsening of diabetes, unless we educate them.
Thank you.
It is working steadily. Thank you so much. And thank you, Dr. Amit. Thank you so much. Just a small we are in problem today because of the today's scenario in Pune. We are debating whether to keep alcohol or not. The advice is not to keep unless you have drivers with you. And so please suggest to me what to do. But our thinking today is can we go next time in a big way with proper things. If at all required, someone else please request. We can manage it.
I am on the verge of dementia now. But,
Tushar आहे बाहेर. Please join for dinner. And whoever request, please meet Tushar.
प्रश्न विचारण्यासाठी बोला.